Hi everybody, my name is Blair Nixon and I'm here introducing chemotherapy-induced nausea and vomiting. And of course I attend Columbus State University. I'm presenting here in front of two of my nurse colleagues and one of my preceptors. So enjoy. So this also says chemotherapy-induced nausea and vomiting. The question that one might ask is, what is induced chemotherapy-induced nausea and vomiting? So this is related to the direct infusion of chemotherapy agents into a patient's bloodstream with the ultimate goal of treating cancer. The horrible side effects, as one might know when they hear the word cancer chemotherapy, is nausea, vomiting. So cancer is a complex disease that requires symptom management and can be viewed as just as difficult to treat as the diagnosis itself. Chemotherapy-induced nausea and vomiting involves frequent management in order for treatment to not only be effective, but tolerable. The number one way to resolve this is providing patients with the appropriate antiemetics and also educating staff and healthcare providers as well. Some risk factors for chemotherapy-induced nausea and vomiting are women and individuals less than the age of 50. Previous chemotherapy cycles were CINV, also known as chemotherapy-induced nausea and vomiting, was not effective. So it's kind of a predisposition to know that, hey, they may not tolerate the chemotherapy that well as they did in the previous cycles. There are anticipatory effects. I've seen a lot of patients, in adult and adolescents alike, where chemotherapy hasn't even begun to infuse. As soon as they walk into the clinic or get admitted, they become nauseous. It's the anticipatory effect, that predisposition of that they know what's going to happen. They know what's expected. Also, tumor burden and location is also a risk factor, as well as fluid and electrolyte imbalances. Also, poor antiemetic regimens as well. A lot of the time when you try to find out why their nausea and vomiting isn't controlled, is because the patients weren't taking their antiemetics as prescribed. They weren't taking it around the clock. They weren't trying to beat the nausea and vomiting. We also educate our patients and say, take the nausea medication even when you're not nauseated. So when it does happen, you're kind of like not chasing it to begin with. We also know that this chemotherapy-induced nausea and vomiting can be self-debilitating. It often requires frequent management in order for treatment to be effective. And a lot of times we have to educate physicians and be advocates for our patients in order for them to successfully treat their symptoms and improve their overall well-being. We're not only treating the cancer, but we're treating their psychological well-being too. The objective of this project is to adequately treat and educate patients as well as healthcare providers about chemotherapy-induced nausea and vomiting. Also, we want to implement the new evidence-based practice facility-wide, not just in clinics that are connected to the hospital, but facility-wide. For example, at Texas Children's or Emory Midtown, we want it to be effective everywhere. So when a patient goes inpatient or the patient is discharged and goes outpatient, we want them to be able to receive the same care and the treatment to remain effective across the board for the duration of their treatment. So the need, again, of this project and also this evidence-based protocol is, in the effort to provide the best care possible, evidence-based practice will be utilized in preventing and adequately controlling CINV. Not only education is key, but trial and error may be utilized as care may be individualized. One antiemetic may be more effective than another. Of course, we all know there are numerous medications out there. We have to look at the patient individualized. Of course, we consider the chemotherapy that is being infused, but one medication may not work for me as it may work for you, Robbie, or you, Casey. So again, CINV is the psychological advancement related to acute or delayed nausea and vomiting, directly related to the infusion of a chemotherapy agent. Also, chemotherapy agents can be oral or go intravenous or intrathecal as well through the back. the spine. Sorry. So acute nausea and vomiting, there are two classes, acute and delayed. So acute nausea and vomiting is classified as symptoms that arise during the first 24 hours after treatment is received. And then delayed nausea and vomiting is when symptoms arise after the first 24-hour period. Regardless of the time frame, providers must take into consideration the classification of the drug received and treat accordingly. I know some common platinum-based drugs, as we know, can intensify symptoms and often last well beyond the 24-hour period. So special consideration as well is considered in what type of the medication I was received and when it was given, and if previous antiemetics was successful in treating the patient's nausea and vomiting. Of course, if left untreated, irreversible side effects can occur, such as anorexia, dehydration, kidney failure, and chemical imbalances. So my PCOT question is, how does effectively managing chemotherapy-induced nausea and vomiting benefit a patient's treatment and regimen outcome in comparison to none? And the reason I say in comparison to none is because a lot of times when we receive phone calls on the patient's behalf is we ask, did you take your antiemetics? When's the last time? Why didn't you take them? X, Y, and Z. We have to investigate it further. So some general risk factors for CINV is, like I said before, previous experiences with uncontrolled CINV and past chemotherapy cycles. Patients younger than age 50 commonly experiences symptoms. It most commonly occurs in women. Again, we're looking at fluid and electrolyte imbalances and location of tumors or the cancer itself. So the patient experience, like I said, we're not only treating cancer or the CINV, we're also treating their mental well-being and their conception of their cancer diagnosis related to nausea and vomiting. So the most negative fear consequence related to a cancer diagnosis, as I said before. It has debilitating side effects. Treatment can become ineffective. Again, there's anticipatory nausea and vomiting and loss of appetite. Loss of appetite is related to the chemotherapy agent itself, but even when the nausea and vomiting is out of control, patients can't keep their food down. They may try and eat, but it comes right back up. In effects in relations to the patient's diagnosis, when nausea and vomiting is not controlled, we find that providers sometimes tampering with their chemotherapy doses, maybe lowering the dose, and doing that can, of course, there's the benefit of it, of allowing the patient to tolerate their chemotherapy cycle, but then we're looking at them not being treated adequately according to textbook standards and beating their cancer or curing their disease. So also thirdly, educating patients about what's expected will result in more effective coping skills as well as increase their quality of life. Before the administration of chemotherapy, all patients are more likely scheduled antiemetic premedication in the efforts to prevent nausea and vomiting or make it more tolerable. Some common antiemetics are aloxi, Emend, Zofran, dexamethasone, and Kytril. Also, we find patients who decide to self-medicate outside of the facility with cannabis and other some alcohol as well. We've seen patients who admit to that. It kind of takes the edge off, although it's not as effective, some studies show. So yeah, even though patients self-medicate with cannabis, we have been seeing where patients were prescribed pharmacy doses of cannabis in order to help with their side effects, which have also been effective. So let's treat and educate. The primary prevention is prophylactic treatment and education of all healthcare providers, patients, and caregivers. Again, we're going to circle back to scheduled dosing. We're going to give pre-medications before we start treatment, and also throughout, depending on the duration of the treatment. Normally, we see Eloxy, Emend, and Zofran giving every 6 to 8 hours. We also encourage and implement the patients to continue their regimen at home, again referring back to beating the nausea and vomiting before it comes. So as far as healthcare professionals, We want to provide research and new practices to all healthcare professionals. We want to contact the administrators and directors about requested evidence. We want to implement the change into a trial run of all newfound research that I will provide to the nursing administration about the newfound research of controlling CINV. We want to gather new evidence and compare to previous data. We want to compare our current data to previous data of patients complaining CINV and how tolerable their symptoms were compared to now and then. And then we want to regroup, evaluate, and make changes as needed. So we will also evaluate the project we will also look around evaluation at month 2. I didn't want to extend it too long because of course these are humans and we are also trying to evaluate their care and need as also their well-being. We want to obtain data on the chemotherapy given, scheduling, and antiemetics prescribed. Also interview patients on any new or worsening CINV and also collaborate and review care plans with providers. Also, I want to point out reviewing patients' charts. As nurses, sometimes we check patients' orders before we submit them to the pharmacy. And if we can see a trend in their chemotherapy dosing declining from what it was from their first cycle to now, we can kind of compare or go through the notes or ask the provider just to see why the chemotherapy dose was adjusted. Or we can also look at antiemetics to find out what worked best for them in the past and to see what's working now for them. So the expected outcomes are the control of the patient's CINV, completed treatment regimens, because that is the whole goal of treating cancer. We want to cure it or make it tolerable or extend or prolong their life as long as we can. And also we want to continue support and implementation of new evidence-based practice. Here are the references as well. Just a few other key points I wanted to add in there as well is the ultimate goal. We also wanted to talk to the patients individually again. Again, we want to sit there and also evaluate what worked for them in the past, how they're taking their medications, what their previous and current connotations are of their disease, as well as their nausea and vomiting, and also their caregivers. A lot of times we have to educate and talk to the caregivers. And we also see that a lot of caregivers, their socioeconomic status, they may not know how to read or write, or they may not have gone up past 3rd grade. So we also want to think about that and educate them, and at each visit to ask, hey, can you tell me the dose? Can you tell me how many pills to take at this time, X, Y, and Z? And is it working for your mother or father, or is it working for your son or daughter? So that's very important in the care of these chemotherapy patients. So that's it. If there are any questions, feel free to ask. Again, my name is Blair Nixon. I just introduced chemotherapy-induced nausea and vomiting and the way to treat it effectively in our patients. Thank you.